15 minutes before our next speaker. And I'm sure after John's presentation, there'll be many members of the audience who'd like to ask questions. We have a roving microphone, I believe, in the room. Yep, at the back there. What I would probably, is this microphone live for John to use?
Yeah, it must be.
And what I'll do is I'll take hands as I see them, and if you could perhaps say into the microphone who you are, what organisation you represent, and then obviously the question. The first one I saw is the gentleman at the back there with the yeah.
Question for John.
Who are you?
Gareth Dawn from Howell's Head Care Farm. I'm just interested to find out what the signposting situation will be for an organisation like myself to get in touch with the GP commissioning body.
Yeah, a very good question. Obviously, it's one of the things that lots of people have been talking to both ourselves and to people like Anne and Brian about as well. First thing to say is that the Practice-Based Commissioning Consortium in the City are quite small organisations in terms of their infrastructure. Some of them have 1 or 2 staff working for them full-time, and all the rest of it is basically GPs committing parts of their week to be freed up from their clinical work to actually run their organisation. So what we've been trying to do is to make sure that we get a shared view on what the responsibilities are that the Practice-Based Commissioning Consortium should take on first, what support the PCT should provide to them in doing that, and as part of that, working out, if like, what's the pace at which people start to engage with others. So if I give you an example, and colleagues might talk about this later, the 2 areas that the Practice-Based Commissioning Consortium leads would like to focus, 3 areas would like to focus on most during 2011-12 are urgent emergency care, old people services and long-term conditions, and prescribing. So that does not mean that they might not have an interest in other things, but all the other things will be carried on, will be run by the PCT during 2011-12 as is. So I think what I would say is that if it's in any of those areas, then it might well be the case that it's worth you getting in touch either with the consortia or probably, to keep it simple, dropping a note to somebody like me or Phil Corrigan in the PCT saying we'd really like to come and talk to the consortia about X, Y and Z. I'm not trying to be control freak, you can by all means write directly, I'm just trying to minimise the amount of stuff that they get, because at the moment, as they'll tell you shortly, they're spending an awful lot of time just understanding what will it be, what will it mean to be a statutory organisation, and how do we as practicing clinicians, they, not me, make sure that they make most value-added contribution, and in fact, what sorts of managerial and technical support will they need sitting below them to help them do that. So it's a bit of a long answer, but I think that what we will certainly be doing over the next few months, because we're effectively going live with the consortia taking on significant responsibilities for those 3 areas from the 1st of April, and with a range of PCT staff effectively working for them while still sitting within the PCT. So I think as we work through that between February and March, I would say that commitment by April will be able to put something out to people through yourselves to say this is how you would be able to access either the PBC individually or collectively. Because there are a range of things within those areas I just mentioned where the PBC agreed to do it once together. There are other elements that they would want to do like slightly differently to suit the needs of their particular population. I hope that helps.
Thanks, John. It's not a precise science, I'm strictly taking the answer so we'll go. The next one is my colleague here directly in my island. Quite proud true this morning. Thanks for your patience.
Thank you, Councillor. My name is Lawrence Wood. I'm asking this question as a member of the public, although I am a member of a number of public patient involvement forums in the city. Councillor, question to you, and some guidance really. I am concerned about the heavy involvement and overseeing role of the council and scrutiny board in the city. Obviously, the council is politically orientated. It has a short life compared with health, which is a very long-term issue, long-term matter. I've seen in my experience certainly 2 JSNA papers produced, and that's in the last sort of 4 or 5 years. Why are we inventing another one? And what's your view in terms of the influences that political issues will have in the council on health policy in the city?
Thanks. Yeah, in terms of the JSNA, we have been charged with obviously working in collaboration with the GP Consortium in a health and wellbeing model, as far as we understand, the need to at least tinker with, if not redesign the current JSNA. I'll give you an example of how I see things from an elected member's perspective. I've been elected member of council for 3.5 years, and it really wasn't until the latter stages of my involvement with the health board, and certainly going forward and looking at some of the new challenges that the health and wellbeing board is going to bring our way, I actually picked ours up and had a look at it. Now, I think that's quite telling in itself. And I said at the top of my presentation, it's sometimes a document I think that has to be seen to be done rather than done to be seen. And I think really one of the challenges for us is to produce a working document that not only has a sign up from a political council perspective, but also a GP perspective, that can actually be seen as the blueprint with some clear objectives, some pathways to get there to deliver some tangible health improvement outcomes. So I'm actually quite comfortable about reinventing or re-examining that particular document. Interestingly, in terms of politics and how we can effectively, I mean, what's the average life for anything in the NHS in terms of changes? About 5 years. And of course, government...
2.5 for
Is it? 2.5 for chief exec, yeah. But changes will inevitably come with a change of political party. One of the conversations we had in the very first meeting of the steering group for the health and wellbeing board was, look, we could be setting up something here that will significantly improve health outcomes for people in this. We have got a joint director of public health who really gets where we need to go in terms of the city with health priorities, in terms of improving everybody's health, but also this phrase that kind of grates with me, because I don't actually see any tangible evidence of it in terms of narrowing the gap. But the fact remains, if you live in Beeston, I think the journey is 13 miles to Wetherby, and for every mile you travel to Wetherby, you add a year to your life. And even though everybody's health is shifting in a positive way, we've done nothing to address that. Those anomalies are still there. And I think that's another job of work we have to address. So my point in the meeting, and I don't mind sharing it with you, was look, we could go down the road of creating something that's actually quite unique, it's bespoke, it's tailored for Leeds, it's got a Leeds perspective. Using the JSNA, we can actually see what we need to do, how we need to get there, and we've got the right people around the table. The coalition government has its 5 years and falls, or it breaks up early, or whatever, we get change. Will we be back to square one where we say, right, what do we do next? And what I would like to see, personally, whatever political changes happen, either at a local level in the city or a national level, that we might not call it health and wellbeing board, we might call it something else, but the broad principles of public health sit with the local authority, working collaboratively with partners from the NHS, continue. I don't want to see a break in that, because I think we are going to spend 2 years developing something that's hopefully robust, fit for purpose, and will deliver tangible outcomes. And then to all of a sudden say, new government, I'm not going to do that anymore, and health and public health will go back to the NHS. How long can we keep doing it? And I think from a political perspective, whoever's in government, the health and wellbeing board needs to be saying, hello, this is Leeds, we've got something that works, look at the model. Don't just come in and say, well, we're now going to change the debt chairs again. Let's say, for example, the health and wellbeing board is up and running, and it's working well, and it's delivering tangible health outcomes for people in the city, and there's a change in government. Colleagues at a senior level in this authority should be knocking on tangible health improvements for people in our city, wouldn't please leave us alone. And there's always going to be a challenge because new ideologies come in, new governments will have their own ideas, as is their democratic right. But I certainly think in terms of this, with the local authority, and GP Commissioner showed Brian will have his own views, but in terms of local authority involvement, this is something that perhaps should have been done way back when the NHS was formed. I remember a bit of Labour Party history, but I know there was a huge debate within the Labour Party at the time of the NHS formation is, should it be a national body that has a national strategy, or should it be a very localised model for communities? And then there was a big debate about whether the public health aspect was actually taken away from local authorities or not. Well, the wheel has actually turned 360 degrees now, we're back to square one. And I actually think that with some creative thinking, with some real collaborative working, with some political will from the city leaders, we can actually make this work. A long convoluted answer. I'm probably going to take us over time, but I didn't want to get all those points in. The next gentleman I saw want to make a contribution was this, my colleague here, right now.
Dave Roberts, I work for the City Council and their economic policy team, but my responsibility is to coordinate the Council's financial inclusion strategy. Both John and Helen touched on preventive services, and in fact Helen sort of listed a number of key issues: alcoholism, diabetes, obesity, etc. Now, I'm sure that wasn't intended to be an exclusive list, but one of the things that partners that we work with are very keen on is the impact of debt. And the importance of advice services in improving people's outcomes, which actually impact significantly on health as well. And I think the concern is that John made a comment about falling through the cracks. And currently Leeds PCT, as do many other PCTs, fund advice services within a health setting because of the recognition of the improvement in health that can bring. In fact, we've actually just finalised a piece of work that was that we were asked to do by the Government Office Health Department on this very subject, on improving health through income maximisation, through advice services, which we published literally within a matter of weeks. So clearly our concern is that, especially with the big emphasis on GP commissioning, whilst our dental advice services can relieve the budget for drugs, when you're in health, a GP commissioner, the thought of cutting your drugs budget to pay for advice services which may have health improvements which might reduce your drugs budget, we're not, it's difficult to see whether that will come out in reality. And so our fear is about the falling through the cracks issue, and I just wonder whether John could comment on that.
Yeah, very good point. A few things. First of all, one of the bits of technical stuff that Ian's heavily involved in is working out which services will be, which services that are commissioned currently by the Primary Care Trust will in the future be commissioned by the local authority. Because one of the issues that we've got to work through nationally and locally is of a range of health improvement services that are delivered across the city, which ones should be commissioned by GP commissioners and which ones should be commissioned by the local authority. So in the category you just described, that's a really good example where we need to be crystal clear, both nationally and locally. Would something like that seem to be something that a public health function within a local authority would be responsible for commissioning in the future, or would it be GP commissioners? So that's not very satisfactory, actually. That means that that's one of the areas we need to watch things falling between the cracks. The second thing I would say, though, is that I didn't say this at this session, but I have before, I'm actually a great believer in public health responsibility moving to the local authority, because for exactly the reasons you said, if we're not careful, we take too narrow a view as to what the determinants of people's health is, and Mark's point about the gap between Central Leeds and Wetherby in terms of health status and life expectancy is right. But all the evidence shows that actually the health service input to reducing those inequalities, their impact is quite small. It's the sorts of things that you're talking about, as well as like economic inequality, educational inequality, etc., that make the biggest difference. So I think the key job for GP commissioners will be to do better than the NHS has done in the past, recognising that those are the sorts of things that can actually make an awful lot more difference to an awful lot more people than some of the small number of very expensive but high profile and politically interesting things that the NHS does.
I will take the guy who's been very patient, just here, and I am conscious of the time, unfortunately, as there we can sort that on. Thank you.
Hi, Martin Newton. I'm on Horticultural People Support, one of the neighbourhood network schemes working in Leeds, and quite a few of us here. My question really is around how local is local commissioning. Is local commissioning going to be big areas where no local, actual local spend will be? I work in a fairly small estate that has quite distinct boundaries and have our own health needs. We're a bit along that line, 13 years less likely will be. And really what I want to know is, will there be local funding available, or is it going to be, like it always seems to be, strategically local, where people come in to each estate, do a little bit of work and then bugger off and leave us to pick the mess up?
I know that Brian's presentation later will address that issue because he's got a diagram that tries to help answer that. So I won't steal too much of his thunder, other than to say that I take the point entirely. I think part of the issue is that not just for the NHS but for the council as well, we've got to really make a reality of these like total place pilots at a very, very local level, where we say for natural communities of a reasonable size, and it might be 10, 20,000 population, whatever it might be, let's really say what is the resource available that we're currently spending across that patch and how can it be used better. And I think, to be honest, that's one of the advantages of consortia, because their membership will be very local. Each of their practices, I know there's a whole range of people that don't necessarily access services through the GPs, but the large majority of people do. And so they will be under huge pressure, even more so than the PCTs have been, to look local first, rather than, if you like, look top down. Because the construction of the consortium will be made up of a whole range of practices whose, if you like, frame of reference will be 10, 5, 6, 12,000 people. So that doesn't sort of like guarantee what you're asking for, but I think it will make sure it's much more grounded than it perhaps has been in the NHS over the last decade or so. I don't know whether Brian wants to comment now. I'll say this slide for later.
No, I entirely agree with what John's just said. I think Martin knows we already actually work on the water of the state, and I think the real strength that we bring as GPs is that we work with our patients on the code face from day in, day out. We start to understand the issues that are facing and also the benefits there are about local interventions, and we have a very much longevity time scale rather than looking at short hits, people parachuting in and being gone overnight.
At this point, my colleagues at these voices are going to freak out a little bit, but if you do ask me to chair these sessions, you probably know what you're going to get, which is deviating from the schedule somewhat. And I can see one or two other hands that come up. So what I propose to do is, obviously, I think we've got the people in the room this morning that you want to talk to and you want to ask questions of. So I'm just going to extend these sessions a little bit. We'll take a break a tad later and perhaps truncate the interactive session, because I'm not sure the room this size how effective that would work anyway. So if you see another hand pop up, gentlemen. Yeah.
Everyone from Touchstone. I was just wondering, while recognising the comments that were made about the constraints on the finance that's available, and we need to take things out and put new things in, how you can square that with the comments that Ellen was making earlier about preventative work that you can demonstrate a payback on, but that payback potentially over many years and certainly not in current funding rounds.
That is the million-dollar question. I think that the issue is that a lot of what I've seen in my time in the primary care trust demonstrates longer-term financial benefits, but that doesn't allow you to get through the short term. And so the reality of the world is that whilst ever the financial system works in the way it does in public services, you really do struggle to invest for the longer term. So if you took, for example, a service like Touchstone, which I know reasonably well, I think that is a very, very effective service for people. But if we were to say the sole purpose of having a service like Touchstone was prevention of, for example, admission into a psychiatric facility, no, it isn't, but I'm saying that for argument's sake, the business case wouldn't stack up. But if it was about something broader than that, then it might. I think one of the things we've got wrong over the years in the NHS is saying if we deliver something in the community, it will inevitably mean that less presents elsewhere in the system. It generally doesn't. And that was okay when there was resource increasing every year, because we could effectively pay for the more in the community and keep what was being done in institutions, hospitals, etc. Now it's a zero-sum game. The amount of money we've got today across health and social care is about exactly the same as what it will be in 5 years' time. And so I think being very challenging with voluntary sector colleagues, there needs to be an understanding that if it's going to be something that is put forward on the basis of prevention, the savings that prevention can give, the service has to be at scale to allow you to take something else out at the same time. And that might mean that smaller voluntary sector organisations will need to look at collaborative bids for things so they can actually operate at a big enough scale to do something sufficiently different for a sufficient number of people to allow other bits of the system to reduce. I'll give you an example. One of my personal sort of obsessions is I really like the idea of telehealth. When you go and speak to patients who have been using it, and I have, they think it's fantastic. Telehealth. I'll just explain what it means in a moment. Effectively what it means is a patient with a long-term condition or a range of long-term conditions having a thing, a box in their house that enables them to check all of their vital signs every day. They get sent up the line for a healthcare professional to review them every day. The patient can speak to the healthcare professional by phone, or the healthcare professional can ring the patient. And as a consequence of it, in the areas we've been piloting it, there's been a huge reduction in utilisation of GP services and of hospital services and of community health services. But if you look at the number of people we're currently using it with, it would enable us to save about 1.2 hospital beds, which doesn't save you a single penny. So as a system, it actually adds to system cost. In the days when we used to have lots of new money, we could say we'll do that as well, because it'll improve quality and patients will like it. Unfortunately, in the world we're in now, it has to do more than that. It has to improve quality, and patients have to find it helpful and supportive and help them keep independent. But it also has to enable us to take at least the amount of cost out that it's cost to put in that new thing. I think that's the new world that I think we're all struggling to get our heads around, and certainly people in the NHS are still struggling to get their heads around it. It's a very long answer, but I'll use that as an example to say that I'm all up for making sure we do an awful lot more things upstream, but we have to have a much more hard-nosed business understanding of how do those upstream things not just reduce demand somewhere else, but reduce it at a sufficient scale to reduce the size of that other bit of the system.
Thanks, John. Right, see any more hands? I'll take one more question. The lady right at the top there.
Thank you. My name is Sally Dawson. I'm from the Marketplace, which is a city centre young people's information support and counselling service. With respect, I can't prove it does. Our service does prevent long-term impact, and you can't prove it doesn't. I think you talk about tailored services for Leeds. When I look at the delegate list here, I think what you have is a number of services that can provide a tailored service for Leeds. The diversity and complexity of Leeds is something that the third sector has been addressing for decades. We're very good at it, we're very cost effective, we know what we're doing. My concern is the short and medium transitional process that's going to happen, because a lot of agencies haven't got the capacity to operate at a consortia level, and it will be lost. You've got it here. We've been doing it for a very long time. We're very good at it. You can tell I'm passionate about it. Makes me very cross. I wrote a letter to Mr. Cameron yesterday about it. If we're not careful in Leeds, we will lose the level of diversity that we have. Thank you.
Only to say I 100% agree, and I think that the thing we've got to minimise is, if you like, that we throw the baby out with the bathwater. I mean, that you're entirely right. I think, just to pick on your first point, I'm not saying that it's your job to prove it. I'm simply saying that we don't have an option to invest in more that might prevent things without knowing that maybe we should take something else out at the same time, because that's the zero-sum game of the finances. We wasn't saying there's a chance you say you have to be able to demonstrate it, we say we collectively have to have confidence that it's going to do it.
And we can demonstrate it.
Thanks for that, John. Slightly behind schedule, but as I said, we can make it up